Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. I'm your host, Dr. Becky Carson, pediatric nurse practitioner and faculty from the Duke University School of Nursing. This new peer-reviewed, case-based series is based on the Choosing Wisely campaign from the ABIM Foundation. If you were at NAPNAP's 46th Annual National Conference in Chicago, you may have attended this session that offered new insight into resource stewardship and, yep, you guessed it, the practical application of evidence-based practice. But if this series is all new for you, I recommend you go back and listen to episode 79 that explains the historical perspective and purpose of the Choosing Wisely campaign. When you're ready to join us again, we'll put your knowledge of the pediatric lists to the test as we apply items to a case discussion based on a very common presentation to the emergency department. Let's begin with a few learning objectives. We're going to learn about the Choosing Wisely campaign via this case on syncope and apply concepts from the Choosing Wisely list to help guide your management and remain a good steward of resources. And lastly, because making decisions involves the whole family, I'll talk with you through some of those tough conversations to create allies out of nervous parents or colleagues who want to do more, even when it isn't indicated by the evidence. If you're ready, I'll set the scene and present our first case. All right, pretend you're a pediatric provider in a busy emergency department. It's a gorgeous summer day with temperatures pushing 100 degrees. It's the kind of day where you can see the wavy heat radiating off the asphalt, and you're sweaty within moments of leaving the air conditioning. The next patient to be seen is a previously healthy school-aged child who spent the day touring the local zoo. The child started feeling bad at the picnic lunch and was getting up to tell the teacher about feeling lightheaded. But after getting up, things felt even more dizzy. Spinning. First a couple of stars, and then everything went white. And plop! The child fainted on the ground. There was no significant head injury. The teachers rushed to the scene, and they notice a couple of abnormal movements. But before they know it, the child is awake. The syncopal episode lasted less than a minute, and the child awoke with a normal neurologic baseline. No sleepiness, no loss of bowel or bladder function. In the emergency department, the caregiver is able to report that the child is just like themselves now. There are no red flags in the past medical history or family history. On exam, vital signs are all within normal limits, and the physical exam is only remarkable for a purple tongue from the Gatorade and popsicles. You're undoubtedly working through the differential diagnosis in your head right now, thinking methodically about what fits this constellation of symptoms as it meets the pathophysiology of the case. You think about the hot summer, how the child was outside in the heat all day, undoubtedly dehydrated, which places orthostatic hypotension and postural syncope at the top of your list. The syncope occurred alongside a prodrome that included lightheadedness and seeing stars. When you consider that the child had just changed positions to stand up and find the teacher, it's the classic recipe for a drop in blood pressure leading to a temporary cessation of adequate cerebral blood flow. When this happens and the person lies flat, cerebral blood flow is restored and mental status quickly returns to baseline. This most likely indicates an autonomic-mediated syncope, which comprises up to 69% of identifiable causes of syncope in pediatrics. Let's take it back to the patho to further reassure ourselves of this diagnosis. Our patient was most likely not getting enough fluid for the output in insensible losses on this hot summer day like today. We knew about the prodrome complaint while eating a picnic lunch. But, there's something key about this picnic lunch. It's on the ground. The blood pools in the lower extremities, and as soon as they hop up, there's suddenly not enough venous return. So not enough preload. So therefore not enough stroke volume. And remember that children often experience tachycardia rather than hypotension because of their immature baroreceptors. So all this adds up to not enough cardiac output. Not enough cardiac output means we're not feeding the brain essential oxygen and glucose. So lights out for about 1 minute typically. Those abnormal movements were most likely myoclonic jerks that are common in syncope. Since I've trained you so well, let's think about the differential some more. Never forget to take a pause and think about what else should be considered. That kind of intentional reflection is essential for metacognition and a thoughtful differential diagnosis. What about seizure? The quick return to consciousness without a postictal period is reassuring against seizure. Other key history items steering us away from seizure include the lack of incontinence, no fever, and those abnormal movements were not rhythmic or symmetrical. Good thought, though. Okay, well, what about a cardiac etiology? All right, I'm listening. Cardiac syncope can be subdivided into 3 main categories: dysrhythmias, structural heart disease, or myocardial dysfunction, all of which can be lethal. Most cardiac syncope is related to dysrhythmias, most commonly SVT, often caused by Wolff-Parkinson-White syndrome, but arrhythmia can also be caused by prolonged QTC interval or Brugada syndrome. Most of the time, cardiac syncope has red flags that cause us to consider this etiology. Things like chest pain, palpitations, syncope with exercise, or a cardiac family history. A significant cardiac family history would include seizures, pacemakers, defibrillators, arrhythmias, cardiomyopathies, history of sudden cardiac death at an age younger than 50 years, or any unexplained death in a first or second degree relative, including car accidents or drownings. So, what should we do to reassure ourselves against potentially lethal cardiac etiologies? Let's talk more about the common diagnoses and let our Choosing Wisely list guide us. Since most cardiac syncope is related to arrhythmias, you should definitely order an ECG. This is an inexpensive and non-invasive way to look at the electrophysiology of the heart and reassure ourselves against the most common cardiac cause of syncope. What about an echo? Okay, first let me ask you, what does an echo evaluate? It uses sound waves to examine the structure and blood flow of the heart. And since this patient has an absence of red flags, an echo is unlikely to provide diagnostic value in finding a clinically significant structural defect. In fact, the Cardiology Choosing Wisely list specifically recommends against echo. The AAP Choosing Wisely list by the section on cardiology and cardiac surgery tells us, quote, "Do not order an echocardiogram for the routine evaluation of pediatric syncope in the absence of a concerning history or ECG abnormalities." End quote. I want to make sure you're reading in between the lines here. If there is a concerning history or ECG abnormality, by all means, feel free to consult cardiology and have a discussion about the merits of an echo. Just don't go ordering one on this patient. There are several other rare causes of syncope in children that we won't explore here. But in those cases, you may consider serum studies if the history suggests anemia, electrolyte derangements, pregnancy, or ingestion. Certainly, head imaging or an EEG would be valuable if there were concerns for a neurologic etiology. I'm proud of your skillful reflection on expanding your differential. I firmly believe that such thoughtfulness can also help you be a better steward of resources, too. Now it's time to reassure an anxious caregiver, teacher, and your pod buddy who really want to get additional studies that won't add prognostic value to a very reassuring presentation of vasovagal syncope. What do you say to calm their nerves and gain a partner in the child's care at home and school? I always start with empathy. acknowledging that I can see how much the caregiver loves the child and that their health and safety is my number one priority too. This puts the child at the center of the conversation and makes it clear that you are a teammate. Start by sharing what you know. Use simple terms and share how this is a straightforward case of syncope caused by dehydration and the child's nervous system not responding well to the hot day. Tell them, the most important part of this whole visit was all those nitty-gritty details you provided. I asked a lot of questions, and all of your answers perfectly fit this pattern of syncope. And also give them some relief by noting how common this is in pediatrics and making it clear that your job is to consider the acute care differential. I see children like this all summer long, especially now that climate change has led to hotter, drier summers. But since it's literally my job to think of the worst case scenario, we're going to make sure the ECG is normal, and if so, we can feel really confident that a structural problem with the heart is very unlikely. Families often need something to do. Remember that concept from our last episode that our primary motivating force is to avoid anxiety? Well, rather than getting an echo to reassure against structural defects, I recommend they go home and drink a bottle of electrolyte-containing beverage, then chase it with another bottle of water, and eat a salty snack. A slow increase in outdoor physical activity to gain endurance and conditioning while minding heat advisories can help prevent this from happening again. But for many kids, syncope will happen again. 60% of kids who faint once will have at least one more episode in their lifetime. When lifestyle modifications fail to prevent syncopal episodes, you can begin to consider pharmacologic interventions. And when the ECG is normal, you're going to continue with the PEDS-NP mottos and offer clear, objective return criteria. Come back to see me if your child has exertional syncope or chest pain, an unexplained post-exertional syncope, syncope without a prodrome, or syncope in the setting of a new concerning family history. While this case is built upon clear evidence-based practice, the Choosing Wisely campaign is an effective tool to help have conversations with nervous caregivers to justify our decision-making and offer reassurance during that conversation about what is necessary in the medical workup of a child with syncope. Just imagine the kind of comfort and reassurance these caregivers have after a discussion with you that shares all of your brilliant foundational knowledge in a way that keeps their child at the center of the conversation, clearly cites the evidence, your rationale, and how you made that decision, and then partners with them for better outcomes. I hope that you'll join us next time when we dive into the American Academy of Pediatrics Choosing Wisely lists for dermatology and gastroenterology, hepatology, and nutrition, in a case that I can guarantee that you've seen in practice, no matter what your setting is. Don't forget to like and follow the PEDS-NP, where we discuss the practical application of evidence-based practice in a conversational way that helps you synthesize and transform the best practices from the literature into your clinical bedside skills. Thanks to the acute care P&P faculty who peer-reviewed this episode. The PEDS-NP is built on grassroots foundations in communities of interest. So share it with a colleague, pass it along to your classmates, and text it to a friend. There's no relevant disclosures for this episode of the PEDS-NP. Follow me on Instagram at the PEDS-NP podcast. Email me at thepedsnp@gmail.com. And remember, this isn't just a podcast. You're providing evidence-based reassurance and comfort for families. I'm Becky Carson. Take care.